Most people see dentistry as clean money and a stable title. What it really is at every level is a ladder built from pressure, debt, and hand skills judged in millimeters. The fastest rise rarely comes from charisma. It comes from surviving years where one bad score can move your whole future. Level 1 is dental student, and the glamour dies fast. You are memorizing head and neck anatomy at 1:40 a.m., drilling plastic teeth under fluorescent light, and watching tuition stack into six figures before you touch a real patient alone. This is where ambition gets audited. Then comes preclinical lab. The handpiece screams, the faculty circles, and every crown prep gets measured like a confession. You learn that dentistry punishes sloppiness in tiny increments. A half-millimeter error becomes your whole personality for the afternoon. The first real patient changes the room inside your head, never asks if this will hurt, never trusts you with rent money and fear in the same appointment. You discover very quickly that technical skill and chairside control are separate currencies. By the time you hit clinic flow, speed starts hunting you. One patient needs fillings, another is late, another cannot afford the treatment plan. And faculty still want perfect margins. You stop thinking like a student for moments at a time. Then the next mistake drags you back. Some classmates angle toward general practice. Others look at specialties because they want status, complexity, or a bigger ceiling. Oral surgery attracts a certain mind. You have to like anatomy, blood, force, risk, and the idea that calm hands can command a chaotic room. Your resume turns surgical. Externships, research, high-class rank, letters from people who have seen you stand still under pressure. You spend weekends in hospital corridors trying to look useful, while residents move at a speed that makes dental school feel protected. Interview season is a polite stress test. Programs ask about your failures, your grades, your stamina, your reasons. Everyone in the room was strong somewhere else. Now you are competing for a place where being smart is assumed, and emotional steadiness starts to matter more. If you match into oral and maxillofacial surgery, the title sounds triumphant for about 5 minutes. Then residency begins. The hours get longer, the hierarchy gets sharper, and your mistakes stop being academic. Swelling, bleeding, airway risk, infection. The body answers back immediately. Intern-level residents do the invisible labor first. Notes, consults, pages, overnight call, emergency add-ons, floor work, and cases where you mostly retract and anticipate. Your body learns the hospital before your ego catches up. Sleep becomes something you remember rather than something you have. Extraction cases teach speed with consequence. Impacted thirds, broken roots, dense bone, patients who waited too long and arrived swollen, angry, or scared. Your attending watches every move, because confidence without control is dangerous in a mouthful of blood and limited visibility. Then trauma hits, mandible fractures at 2 a.m., facial lacerations, cracked orbital floors, drunk patients, frightened families, emergency department noise. This is where the specialty stops looking like premium dentistry and starts looking like surgical responsibility with dental origins. The ceiling rises. Orthognathic cases, pathology, reconstruction, full sedation protocols, teams moving around sterile fields with no patience for hesitation. You begin to understand why oral surgeons are paid differently. They are selling judgment under pressure, not just procedures. Mid-residency, your hands finally quiet down. You can place plates, section teeth efficiently, and speak to anesthesia without sounding borrowed. A small shift happens here. Nurses trust your requests. Attendings give you more room. Competence becomes visible before confidence fully arrives.
Senior residency is where leadership starts costing you sleep. Juniors call you first. Complications land on your list. You manage clinic volume, hospital politics, scheduling pressure, and the emotional temperature of people beneath you. Technical mastery matters, but authority now lives in decisions. After training, the path forks hard. Academic surgery offers prestige, teaching, research, and a slower financial ramp. Private practice can turn skill into serious money fast. if referrals trust you. The market does not reward the same thing as the hospital. You have to choose your battlefield. As an associate oral surgeon, you enter the referral economy. General dentists send the cases. Your reputation moves through waiting rooms you never see. Remove wisdom teeth cleanly, place implants predictably, answer post-op calls well.
And the schedule fills. Mishandle pain or communication, and the stream thins quietly. Ownership changes the math again. Now you are surgeon, operator, recruiter, brand, and risk manager. Cone beam machines, sedation permits, payroll, malpractice coverage, implant inventory, marketing, lease terms. The room looks more polished, but more of the pressure now comes with invoices. At the top tier, elite oral surgeons handle full arch implants, complex reconstruction, major referral networks, multiple locations, and incomes that can outpace many physicians. They look composed because they have repeated hard things thousands of times. What you're seeing is scar tissue turned into poise. And here's the part ambitious people whisper past. Every level pays you for a narrower kind of self. Your hands get steadier, while the margin for error disappears, and one bad call can haunt a patient for years. What would the next level cost you to reach?